Thank you, sir. Thank you, Dr. Quresh, for inviting me for this very nicely crafted course. So I'm going to go to the other side and say that patient who comes to us with symptoms which we see quite often, like headaches or loss of vision or double vision, and what are the cases where we should be rushing to say that this patient requires something, and in some instances requires investigation immediately. So this is a case, blurring of vision for near for the right eye, visual acuity being 6, 9, and 8, right pupil being larger than the left, and little sluggishly reacting. Patient also complaining of headache. So one thing which we need to remember is that when the patient has difference in pupillary size, that's not really a sign of optic nerve disease. When there is anisocoria, when there is a difference in the pupillary size, it is generally an autonomic system problem. It can be either a sympathetic system problem or a parasympathetic system problem. And that's how, this is how the patient looked like. Now see here on the top photograph, you can see that the left pupil, left eye, which patient does not have much of a problem, has a mild ptosis. And there is an anisocoria where right pupil is bigger than the left pupil. So when you have this kind of difference in the size of the pupil, the next step would be to see what happens to the difference in the size of the pupil when the room lights are turned off and when the room lights are turned on. In other words, we want to see what's happening to an isocoria when there is a bright environment versus a dim environment. Here, if you see in a dim environment versus a bright environment, you see that anisocoria, the difference is much more in a dim environment. So in a dim environment, when the room lights are off, normally pupils are supposed to dilate. If anisocoria became worse in a dim environment, meaning thereby that the smaller pupil did not dilate, patient, in other words, is having a sympathetic system problem. So now patient has a sympathetic system problem with the left side. She's also exhibiting a little bit of ptosis. We are dealing with Horner syndrome. Now, why it is important for us to know? Because a lot of these patients can come to us with complaints, vague or severe complaints of headache or neck ache. And let's look at it a little bit more in detail. This is another example of patient with left pupil being smaller than the right pupil. Remember, Horner syndrome with pain is a medical emergency. And why is that? The pain can be in different parts of the head or neck. Horner syndrome with acute facial or a neck pain, patient might be harboring a carotid artery dissection. Now, why that is important to us? One in the red tells us that it's important because 50% of these patients in the series which came out from Atlanta, 50% of the patients who had carotid artery dissection, they actually presented to us first. And why is that important? 60% of these patients have permanent neurological damage and 5% mortality rate. So patient who came to us with complaints of headache or neck pain, harboring a problem which can be fatal. And that's the reason why, and 50% of them actually present to us first. The other possibility, Horner syndrome with shoulder, scapula, arm or hand pain. So if patient has anisocoria and is complaining of pain more down, patient might be having Pancoast tumor or apical lung tumor. Again, 20 to 50% of these lung tumors would have Horner syndrome on presentation, and some of them can present to us first. Patient complaining of daily unilateral headache is reader syndrome or trigeminal neuralgia, and generally these patients are managed by neurologist. So that's about scenario number one, patient coming to you with headache or neck pain, and you found anisocoria. The second step would be to find out what happens to anisocoria in a dim versus bright environment. This is another example of anisocoria with some ocular motility problem. You see, again, patient has ptosis of the right side, and I would be checking ocular motility using a torchlight, and you'll find that the eye which has ptosis also has a larger pupil. And when the ocular motility is being checked, you'll find that there is a limitation of elevation in the same eye. So this is another example. Of course, this is much more obvious where you don't really have to do anything. You know that the patient has a problem, but this again is a medical emergency. Patient has a potential partial third no palsy with pupillary involvement. Now, why that is a medical emergency? Because 10% of these patients who have third no palsy with pupillary involvement can actually die before a medical attention, because they can be having aneurysm of posterior communicating artery which present to us first with a third no palsy and pupillary involvement. 50% of these patients can actually pass away within 1 month, and rest of them can have residual neurological deficit. So pupil anisocoria, we looked at two scenarios. One, Horner syndrome, patient can come to us with headache or neck pain, or patient with a third no palsy but pupillary involvement. A lot of times patient who comes at a later age group has a third no palsy, has diabetes or blood pressure, we tend to attribute third no palsy to diabetes or blood pressure. But if the pupil is involved, if there is a suspicion of pupil involvement, then patient requires MRI or MRA immediately, because that's a potential aneurysm which can rupture and patient can pass away. These are two pupils which generally we end up seeing more in neurology ward and not so much in our OPD, a dynamic oval pupil or Hutchinson's pupil. So if you are caught to see a patient in a neurology ward and if you find that a single pupil is dilated or it has become oval which keeps changing its shape, you saw patient in the morning and the pupil was oval and then in the afternoon it became round again, these two are actually suggestive of early or late brainstem herniation. So that's about third no palsy and pupil anisocoria. Another, since I'm also going to talk about motility, another example where we should be a little more careful in a third no palsy is this video is stopped. But if patient has recovered from a third no palsy and you find that there is a little bit of ptosis which where the lid is jumping up and down when the patient is adducting or looking down, that's a sign of an aberrant regeneration. Again, a feature that you should not ignore, because aberrant regeneration is generally a sign of compression of the third nerve. Now, these are some of the other cases. Patient complaining of a 40-year-old female complaining of a near vision problem, obviously presbyopic age group, so she was given glasses, but this is what she was having. You can see here the left pupil is little larger than the right pupil. So there is an anisocoria, and you can find here that now I'm examining pupil in a dim room versus a bright room, and you'll find that the difference in the size of the pupil was more in a bright environment. So patient who has anisocoria worse in a bright environment, ocular motility being fine, patient coming to you mainly for near vision problem, this patient has ADIS pupil. Again, as Dr. Quresh mentioned, it's not necessary that you found this and you need to do urgent neuroimaging. A simple test in your OPD, and you find here that now left pupil, which was larger, has become of normal size. Patient was the diluted pilocarpine drops were instilled in both the eyes, and you find that left pupil has responded, confirming the diagnosis of ADIS pupil. Generally, these patients don't really require any treatment. In olden days, patients were being prescribed pilocarpine to take care of their photophobia and near vision problems. But pilocarpine comes with its own set of problems, and that's why we have stopped prescribing these patients. They just require maybe sometimes near vision glasses and a sunglasses when they go out. So that's about the pupil. This is just a demonstration of RAPD, which is the other set of pupil, as Dr. Quresh mentioned. Any patient who comes with a loss of vision, which is not explained, this is the most objective way to say that it's not cataract or it's not refractive error or it's not retinal problem, but it's neuroophthalmic problem. It's the most objective test of a unilateral pupillary disease. And you see, when the torch is shown on the left eye, left pupil, instead of constricting, is dilating, signifying that patient has optic nerve problem in that eye. These are the steps of doing pupillary evaluation, and that should be actually a norm in every patient that we see. And this I have taken from Dr. NJK's presentation, where patient should be looking at a distant object in a dark room, and each pupil should be illuminated for an equal time at an equal angle. To end, I'm going to show few patients with ocular motility problem. Again, patient coming to you with diplopia, and patient on left hand side, you find here that he has isotropia with a limitation of abduction in the right side as well as in the left side. So bilateral abduction deficit, there are two possibilities. It can happen in a raised intracranial pressure. So look at the fundus very carefully. Patient may be having raised ICP, or it can happen in the tumors of base of the skull. Versus this patient who has a little bit of lid bump and is not able to look at to the right side at all. This patient had a pontine problem. Ending with this ocular motility problem where you can see that the eye is not moving at all. So when you have either eye which is not moving, multiple cranial nerve effect or effect in the other eye, those patients would require a neuroimaging. This patient had a problem with a cavernous sinus, which can be either a tumor or infection. So in other words, as Dr. Quresh mentioned in the beginning of the course, a lot of these tests can be performed in the OPD by just using a torchlight or a target. A pupil, anisocoria, or a pupillary reflex are important tests. Pupillary reflex tells you about optic nerve disease. Anisocoria is always an emergency unless proven otherwise. And ocular motility, multiple ocular motility problem always warrant neuroimaging. In a sixth nerve palsy, which is quite common than the other cranial nerves, always look at corneal sensation. Because even if it looks like just an isolated sixth nerve palsy, if the corneal sensation is gone, then patient might be having infection of the cavernous sinus, which again can be fatal little later in the life. Thank you so much.